presenting to you a small case study that we've conducted in Lebanon, and the projections of this case study is for you to dwell upon and think, why are we interested in this study? How can one research project lead to another research project? And the value of actually assessing concepts in their cultural context and their linguistic context. So fact B is a quality of life instrument that assesses quality of life during disease. Fact B was dwelt upon in the case of breast cancer, and they formed the fact B, the breast cancer subspecific. This is the quality of life instrument that I will be talking about now in the case of breast cancer. Now, why do we care for breast cancer? Breast cancer affects over 1 million women every year. It's the most common malignancy in women globally. We see the same pattern in Lebanon as well as the Middle East. If we look at the incidence of breast cancer in the country, according to the latest statistics of 2007 by the Ministry of Public Health, breast cancer ranked first among cancers in women, constituting more than 1/3 of all female cancers. Now, why do we care? Because screening and early detection in the case of breast cancer using mammography has led to enormous survival rates among women. So what affects survival rates as acute as prognosis, how well women upon diagnosis can do well and perform well with therapy. And this is why we're interested actually in quality of life. We're not only interested in quality of life during disease, we're also interested in quality of life post-disease. In this small pilot study that we've conducted in Lebanon, our purpose was to see how well will fact B perform post-disease. What are additions, insertions of items, deletions that we could empower this instrument on in order to focus on quality of life of women, not only during when they're taking the therapy upon diagnosis, but as well as during their different intervals of their lives. Now, why do we care for quality of life instruments? What's their value? And why is it important that they're culturally and linguistically sensitive? It's because if we look at the doctor-patient interaction or communication, it definitely leads to improved patient-doctor communication. It also improves the satisfaction of patients in relation to their overall mental health. It leads to reduced anxiety, improves role functioning, and also improves quality of care, because when we're managing women or when we're managing everybody with the disease, it's very important to understand not only the biological aspect of the disease, but also the psychosocial aspects, because the psychosocial aspects ultimately affects prognosis and response to therapy. Now, quality of life instruments, in brief, they allow also to evaluate clinical interventions. So especially if our clinical interventions have a target on mental health outcomes, and the fact that they allow us to compare the mental health status of women during disease, post-disease, and allow us to understand, is it essential that specifically do these women need a more enhanced psychosocial care, less enhanced, and so on. Now when we look at standardized instruments in the Arab world, we really don't see a lot of quality of life instruments that are standardized and translated, adapted, and used in the Arab world. So this exercise that I'm going to be talking about right now presents a novelty. And why do we care? As you know, there are inherent cultural, religious, as well as ethnic practices in the region that are specific to those regions and that ultimately affect quality of care, approach to screening and early detection, and also management during disease. So these factors could deter or reinforce screening, as I said, influence quality of life, as well as disease management, and more importantly, actually, is compliance to treatment. They also could impact the perception of breast cancer as a disease. Because oftentimes, you know, breast cancer is not a death sentence. However, the psychological factors that women pass through upon diagnosis, even if it's early stage, are enormous. And by having those types of quality of life instruments, we can better understand how to reform our language as clinicians, public health practitioners, social workers, when we're dealing with women diagnosed with breast cancer or survivors from breast cancer. As I mentioned, it's important because oftentimes, especially in the Middle East, and when I present the data, this will be clearer, many times women think that breast cancer is actually a punishment. It's often associated with stigma. And, you know, the role of religion in, you know, disease management is very rather controversial. And in some studies, they show us actually religious women respond better to therapy, and in other studies, they show us the exact opposite. So, but by having a quality of life instrument that we could use to tackle these psychosocial aspects in a very comprehensive, easy, straightforward way, we can standardize results and also conduct comprehensive research studies. When we look at how many quality of life instruments, roughly, there have been 21 different quality of life instruments used among breast cancer population. Fact B is one of them, and when we look at Fact B, basically Fact B consists of 44 self-reported items, and these items are categorized into five main subscales. We have the physical well-being, the social and family well-being, emotional well-being, and the functional well-being, and finally the breast cancer specific subscale. Now, for each of these domains, there are specific set of questions, and we actually ask those questions on a scale from, I'll show you the instrument just briefly, on a scale from 0 to 4, with 0 not at all and 4 very much. And these are the questions, like we have around 7 questions assessing physical well-being. Then we have social and family well-being, emotional, functional, and other concerns. The additional concerns are the specific breast cancer subscale concerns. Now, so why am I showing you this instrument? Because basically this exercise that we've done to validate Fact B revolved around looking at the questions, translating them into Arabic, making sure that the language that we're using during translation is comprehensible, is appropriate, and is culturally acceptable. And then, you know, just to make sure, while doing the translation exercise, we also went and field tested the instrument to see, are these questions relevant to the woman when we translate them to Arabic, and so on and so forth. So this is briefly the instrument. If you want me to go into more details, we can do that later. Now, going back to, so basically that's briefly what Fact B consists of. And if we look at the different translation exercises of Fact B, we see that it has been translated into 17 different languages. And upon translation, it was shown to have good psychometric properties in terms of reliability and validity, sensitivity to change, and clinical status over time. What do we mean by reliability? It means that if I administer the instrument over and over again on the same group of people, that is women, I'm gonna get exactly the same results. So reliability is basically how likely will I be able to get the same result using the same instrument on the same group of women. Now with validity means how likely am I measuring what I'm supposed to measure. So basically, if I'm saying the physical well-being subscale focuses on the physical symptoms that women are, you know, passing through during or post-disease, by validity I mean that the questions that I'm asking are actually capturing the right concepts. So how good am I in capturing the accurate concepts when measuring a certain entity? Physical well-being, emotional well-being, and so on. And also we would like to see if that instrument has sensitivity to change over time. You know, when you're first clinically diagnosed, you're more likely to have, for example, a worse quality of life outcomes than maybe 1 year post your disease and one year post disease free. So when we look at sensitivity to change and pertaining to time, fact B also has been known that it captures that clinical status changes over time, and this is something that is really very important. Also, fact B is known that it is known to be able to depict different quality of life outcomes as per different disease stages. You know, when we talk about cancer in general, usually the severity of cancer is determined by staging, and the staging ranges from stage 0 to 4. As we move on from one stage to another, the disease spread and the disease prognosis is poor. So when they administered fact B over different groups of people with different disease stages upon diagnosis, fact B was also able to depict those different disease stages whereby women with poorer prognosis ultimately had poorer quality of life. So why am I focusing on these concepts? Because it's very important if let's say I'm measuring my weight, I'm measuring my height. I need to make sure I'm using the right scale. Otherwise, you know, whatever concept of weight and height I have might be totally distorted. It's the same thing with respect to quality of life, but we're measuring psychometric properties, okay? So what was our study goal? Our study goal was to translate, and I'm going to focus on the terms because this was the study. So each term means something. So it's not just a sentence, it means something. So first of all, we would have liked to translate the instrument and then adapt it to make it culturally, linguistically acceptable and also comprehensible. And then we did a face validity. And a face validity is whereby you administer the questionnaire to a group of experts, and then they look at your concepts and they look, did we translate well? Did we lose the meaning of the sentence or the phrase or the concept while translating, so on and so forth, okay? And then we wanted to touch upon briefly what were the strengths and weaknesses when we administered fact B, particularly to those group of women, which I will discuss in a few. So the target population for the study were Lebanese women already diagnosed with breast cancer, and they knew about their diagnosis status. So the women knew that they had breast cancer, and this is very important from an ethical perspective. They were being followed up at the American University of Beirut Oncology Clinics. And they were willing to share their experience. Willingness to share experiences is very important, and the fact that we're not coercing women to participate in the study, they are actually voluntarily participating in the study, and by voluntary participation, this was revealed by these women signing an informed consent. So the study consisted of 3 main phases: the translation phase, quantitative pilot testing, and focus groups. The first phase, which is the translation phase, usually whenever we translate instruments, and that's a standard procedure. Whenever we translate instruments or questionnaires or assessment tools, we do a forward translation, which is translation in our case. The language that we're translating to in this case was Arabic. So a forward translation means that I'm translating the instrument from English to Arabic, and then I do a backward translation using also different qualified personnel, because I want to make sure that whatever we translated into Arabic, when I translated back into English, it gave exactly the same meaning. So, and whenever we translate any assessment instrument or questionnaire or tools, we usually do a forward translation and a backward translation. So in our case, the forward translation was done by a clinical psychologist and a social worker, and the backward translation was also done by similar personnel. However, they were not the same people, and it's important that they're not the same people, because you want to make sure that whatever you translated into Arabic retained its meaning. So if I translated and back translated, I'm biased, so I have to choose someone else to do it for me. Okay, now the second phase was a face-to-face hospital-based interview. So what we basically did is we administered the Fact B, the Arabic version of the Fact B, into a group of 33 women who voluntarily accepted to take part in the survey. And as I mentioned, that only women who were aware of their breast cancer status and they were willing to talk about it were selected after informed consent. Now, with the third phase, after we have finished the data collection on the 33 women, we kind of roughly analyzed the results to see what we came up with in terms, how did the women answer those questions, how did the women perceive the instrument in terms of, is it comprehensible, is it respectful, is it annoying or intrusive, and is it too long, too short, so on and so forth. So we did 2 focus groups in order to assert our quantitative phase, and 4 women per group the focus groups consisted of 4 women per group. And as I mentioned, the focus groups aim to cross-validate the obtained results during the interviews in order to come up with the final instrument, the final Arabic format of Fact B. Okay? Now, the focus groups were run by a moderator who had extensive experience in qualitative methodology, and the women who took part in the focus groups were also breast cancer survivors. They came from the same clinics but did not participate in the interviews. And coming from the same clinics is important because we want to make sure that the sample that we're using actually is representative of the second phase of the study. So they weren't just random women, they were women from the same clinics and also survivors from breast cancer. In both assessments, the qualitative and the quantitative phase, the participants were asked to give feedback on the relevance of the questionnaires, of the questions asked with respect to their breast cancer experience. They were also asked to give feedback about the terminology used, the level of questions comprehensibility, and cultural adequacy. And you know, in any research study, before conducting the study, we need to make sure that the study abides by ethical principles. And for this, every academic institution has something that is called the Institutional Review Board, which is a review board that consists of experts in the field who go over your study to make sure that it's ethically acceptable. And they usually give advice to either, you know, reform it to make it more ethically acceptable, and so on and so forth. So we had to use 2 types of consent forms because the study consisted of 2 phases. So we used a consent form for the questionnaires during the interview section, and we used a consent form for the focus groups. And basically, the consent form were obtained from women and privately in a separate room. Any consent form usually explain the purpose of the study, and usually details the strengths and weaknesses and any benefits or harms associated with the study. Also, consent forms usually introduce who's doing the research, who is the principal investigator, and to which organization they belong to. So we obtained IRB approval also from the American University of Beirut, and usually in each consent form that you usually administer before your research, it's important to highlight to your subjects issues pertaining to confidentiality, willingness to stop the interview at any time, even if the woman provided consent, and you discuss with your target population the risks and benefits. So of course, the consent form detailed those in specific and detailed sections, and the women were explained those different aspects of the consent form and were asked to read it, and then were asked for consent. So the first step is you get an IRB approval. The second step is you collect the data. And then what do you do once you collect your data is you enter and manage your data. Once you enter and manage your data, you analyze your data. So basically, and the analysis, because we had a quantitative phase and a qualitative phase. So the data analysis for the quantitative phase, we used the SPSS, the the statistical package for social sciences software, and the analysis was really only basically descriptive analysis and bivariate analysis. And I'm not going to go over the tests, but what I would like to hint at is that when we were analyzing the data, we also wanted to see if fact B could capture different stages of diagnosis, could capture the type of therapy that the women were undertaking, and could capture differences in socioeconomic background, meaning that where women with more advanced disease, could fact B illustrate a better outcome, quality of life outcome, or worse? Are educated women, do educated women with breast cancer have better quality of life or worse, and so on and so forth. So that's in terms of why we would be interested in the quantitative analysis. So basically, the quantitative analysis helped us to understand who the group of women we have, what's their average age, and so on and so forth, and how well is fact B performing. Now, with the focus groups, usually in qualitative assessments, once you do analysis, the analysis usually revolves around transcription and then assimilation of the different data obtained. And when you're doing that, you have to make sure that concepts pertaining to stability, equivalence, and internal consistency are maintained. And it's very important to note that we had only one moderator involved in the transcription and the write-up, which is important because it allows for standardization. Now the results. So when we come to who the women were that participated in the quantitative phase, their average age was 47 years old, and they were mostly married women, and they were very well educated actually. Their main occupations, they were either teachers or secretaries or have never worked. And in terms of their monthly reported salary, the range was, if we look at those ranges, and these are actually important because they kind of reflect, salary distribution when it comes to Lebanon. So it's actually pretty interesting to see this pattern of, reported salary. In terms of smoking, we did assess smoking in terms of cigarette smoking and water pipe smoking. Around 40% of the women indicated that they are either current or previous smokers, and around 30% have indicated that they're either current or previous water pipe smokers. Also, the frequency distribution of the smoking status is also very much similar to the ones reported among women in Lebanon. So really, smoking rates in Lebanon among women and men are really very high, and the order of 40% is actually a reality. No, it's specific to Lebanon. There's an invasion of water pipe smoking for the last I would say, between 5 to 10 years now. And actually, there are many studies in the country showing that water pipe smoking has even worse adverse effects than actually cigarette smoking. It's because of, the frequency, the chemical composition of the tobacco, especially if it's a flavored tobacco. And usually, with cigarette smoking, like you have a pack of 20 cigarettes, which you end up consuming over the day. Now, with water pipe smoking, you have the head. And this head is actually equivalent to one pack. And studies have showed in Lebanon that it's actually equivalent to one pack. And the sad thing is that, you consume it in 1 hour. So as opposed to smoking over one day, you're smoking 20 cigarettes. So it's really bad, yeah. Now, with respect to why do we care about reproductive history? We care about reproductive history because, late age at marriage and late age at pregnancy have been known and postulated in the literature to be risk factors for breast cancer. And why do we care about breastfeeding and oral contraceptive use and hormone replacement use? It's because, you know, breastfeeding has been shown in some studies to protect against breast cancer. The studies on oral contraceptive are controversial, but more towards that they actually can protect from breast cancer. And the studies of hormone replacement therapy among postmenopausal women. Also, the results have been controversial, but more in the yield towards that they actually increase the risk for breast cancer. So this is why, I mean, when we're assessing data, it's important to understand not only the socioeconomic profile of these women, but also their biological profile, as these interplay in, you know, in understanding and analyzing your data better. Now, family history, you know, having immediate family history has been noted to be a high risk for breast cancer, especially if it's the mom or a sister, and also some studies report towards the ancestor. And we see 12% of these women actually indicated that their mom had breast cancer, and 9% have indicated that their sister actually had breast cancer. In terms of stages of diagnosis, basically 50% of the women were stage 1 and stage 2, and the remainder were stage 3 and stage 4. And in terms of therapy status, the majority of these women were actually undertaking therapy when we administered the questionnaire. And as we might expect, that chemotherapy and surgery are the most common management options for women with breast cancer, and this is what the data also has revealed. Now we come to the more interesting part of the study, is when we ask women, what items do you think are relevant, what items do you think are irrelevant, and what do you recommend to be added to the instrument? So when it comes to, and as I mentioned, if you recall, that FACT-B is divided into 5 main subscales. So when we talked about the physical well-being subscale, the most relevant or important parts noted by the women were pain and the ability to meet the needs of the family. The women did not think that staying in bed, side effects post-treatment, and nausea, which is also a side effect post-treatment, were relevant to their case. And this is actually expected, because remember when I first started, I said FACT-B was mainly used to depict quality of life instrument during disease. We were interested not only in translating FACT-B, but we were also interested to see if we want to use FACT-B post-disease, what items would be more relevant and less relevant. Social visits during treatment, in the Middle East, families visit each other, and families usually have nuclear families, and there's an informal open house policy. So you don't need to call to step in, and when people come and visit you, they think they're providing you with social support that you would feel instrumental, and they're helping to back you up. So women actually, they were very appreciative that people were visiting them during their sickness, but they thought that they needed their own space and their own time in dealing with the disease symptoms, and also with the psychological status that they're going through. So they thought that actually repeated visits actually affect their quality of life. And weren't for this exercise, we actually would have not known that. We would, for example, would have taken it for granted that, oh, that's one form of social support that could be conducive to their quality of life. So that's the nice thing about research, because it allows you to translate contextual evidence before generalizing into conclusions. Now, changes in taste during treatment was something that the women really, when women undergo chemotherapy, many of these women, they said that their taste buds change, that they can't taste the food anymore. This is something that the women thought it's essential to be added to to FACT-B. When we come to the social well-being subscale, The most relevant item was emotional support from their family. And usually the family, usually the instrument, in fact, there's question on emotional support from the family, and there's questions on emotional support from friends. The women actually did not think that the emotional support that they need should be from friends. It actually should be from their immediate member. Now, this is something when we compare it to Western literature, it's actually the opposite. Actually, in some published Western literature, it's women value support from friends and view it as more of an emotional backup to them compared to their immediate family. So this is also a finding that, I mean, weren't for this research, we wouldn't have, when we ask women about their sexual life and their feminine related, concepts, how important is that they looked pretty, they retained their femininity, how likely would the disease have affected their femininity. Many women did not, they left this question unanswered. Now, there are many reasons why it would have been. It could have been that women don't think this is relevant in their course while they're taking the disease, or it could have been that it's something very private that that the women are not comfortable enough to disclose it. And when we asked about the emotional well-being, there was the most relevant item that we see, and also consistent with Western published results, is that women worry that they will women who are survivors from the disease, they often have recurring thoughts, what if the disease would come back? And this is why assessing quality of life post-disease is very essential, especially in cases of chronic diseases like cancer. What they thought was not relevant, and what Fact B included in its items, was feeling sad and feeling nervous. And women actually noted that it's very important that the timing when we administer the questionnaire is very essential. Meaning that, I mean, women who are undertaking therapy would definitely have different quality of life outcomes and concerns if we compare them to women post-therapy. For the functional well-being, sleeping well was noted to be the most relevant item, as many of these women during their course of the disease often do not sleep well. This is because of the side effects of the therapy, and also because of their psychological status as a result of the disease. For the additional concerns, what the women noted to be most relevant was they often worried that what if they would be responsible to passing the disease to their kids, or to their specifically daughters. This was a very recurrent theme. Also changes in weight, which are associated with the therapy, and pain in different parts of the body. What the women thought was irrelevant in this subscale were shortness of breath, self-conscious about the way to dress. Often when you're undertaking therapy, the hands become swollen or tender, and women didn't think that feeling sexually attractive was a big deal. And but again, we don't know if they were comfortable enough disclosing those aspects, if we actually achieved rapport with these women to the extent that they would tell us or reflect to us really what's going on. Now, the important thing that we thought which has to do with stigma is pity, feeling pity. Like, there's a phrase in Arabic called haram, which is poor thing. This phrase was really very annoying to these women, because these women felt, okay, I'm not a poor thing, I just have a disease and I'm trying to be a survivor to fight the disease and to go back to my family and enjoy the rest of my life. Also, women worried about the financial aspect of the disease, and this is very essential during therapy when they're taking pain meds and then suddenly the Ministry of Public Health runs out of medications, or they have to wait long hours to get the medications. And so the financial aspect of the disease was something that the women thought need to be added to this to this instrument, because it ultimately also adds on the burden of disease. Now, also doctor-patient interaction was thought to be very important. In fact, the women in our study revealed that they loved the way they interacted with the nurses, and that the nurses were very sympathetic to their condition, as opposed to the doctor. And they relayed that, you know, it's essential that doctors reflect more into their disease management, explain to them better, talk to them in terms of what they expect during the course of management, and so on. To sum up, so women consider the instrument easy, short and simple, culturally appropriate, and pertinent to their own experience. The questionnaire took around 15 to 20 minutes, which is fairly acceptable. And you know, with the different analysis that we've done, Fact B was able to depict differences for women undertaking versus those who finished treatment, women's stage at initial diagnosis, and disease management as a whole. And younger women and those with higher monthly incomes had better quality of life outcomes. Respondents stressed upon that the fact B as is, without the recommended items to be added, is more relevant to their quality of life during disease. And those findings are actually in agreement to what's noted in the literature. The main stressed upon themes were the importance of the role of husband in providing emotional and social support, as opposed to friends and as opposed to immediate family members. Stigma was very important. Worry about passing the disease to their family, worry about, you know, passing away and missing important life events in their children's, you know, life. And then there was the spirituality connection that Fact B does not capture, which was also very highly recommended to be added. Now, husband support was a relevant theme, as I mentioned, and in general, women who had problems with their husbands were more depressed compared to women who did not. And for example, in one Chinese American women study conducted, women perceived husband support as very essential to overcome their difficult experience with breast cancer. This finding was also replicated during our focus group discussions. So during our focus group discussions, actually the same statement was, you know, revealed by women in the focus groups. Also, the husband role was connected with issues related to sexuality and femininity. Some women felt guilty because, you know, they're passing through the disease, and you know, they feel guilty that they're not able to cater to their husbands. And by expressing that they felt guilty, we kind of concluded that the fact that they left those questions unanswered is not because those questions are irrelevant to them. It's because they needed more time to establish rapport to, you know, relay those findings. The literature suggests that around 25 to 33% of women experience problems in femininity and sexuality after a year of mastectomy. And then mastectomy means removal of the breast, the surgery that removes the breast. And usually the recommended or the most heavily practiced is total mastectomy, whereby the whole breast is removed. Women, as far as stigma is concerned, which is also very important and pertinent to the Middle Eastern context, and which also Fact B did not address. So not only the husband, but the society at large imposes certain stigma on women. Because when women, like when they undergo mastectomy, or when they lose their hair, or when they look pale and sick, usually the society is kind of imposes into the women's personal space, and like comments such as, oh, you look pale, oh, how come you lost your hair? Those are, sometimes we might even ourselves like engage in them without noticing that they actually psychologically can be very troubling to those women. Reaction to stigma in different cultures actually is different, and that's really interesting. For example, in some cultures, really women express that they're really indifferent about the socially instigated stigma. In other cultures, like in one study conducted in Iran, among Iranian women, many of these women did a breast augmentation right after their mastectomy in order to, overcome those feelings of stigma. So really, reaction to stigma is also pertinent to different societies, and adding the stigma component into fact B and doing comparative studies in the Middle East will also help us and allow us to differentiate how different societies or countries in the Middle East actually react to stigma. Do they react similarly or differently? As I mentioned, worry about their family was very important in terms of not being able to cater to their family needs, spend time with their families, spend time as in quality time, share with them important life events, and most importantly, women consistently worried that what if they pass their disease to their daughters. The role of spirituality was also very important, and so basically, before coming into this research, you would think or maybe conceptualize that maybe women had resentments because they had the disease. What we found out actually is that the women drew closer to God and they became more religious, and they did not express any negative feelings of resentment because they had the disease. In fact, many of those women expressed that they usually, when they lost their hair, they usually wore something over their head in order not to, to mask their hair loss. One of the women continued to wear a veil even after her hair grew back because she believed that God has helped her to cope with her agony. And other women explained that praying and reading verses from the Quran provided them with immediate relief and actually helped them to deal with their disease better. So this spirituality connection is also not reflected in fact B as is. And I mean, if I look at this data, and based on those findings, I can hypothesize maybe that women who feel who show or manifest a higher spirituality connection maybe will have better quality of life outcomes than women who have less spirituality connections. So that's also an interesting finding. Positive behaviors can be considered as self-destruction mechanisms, and this is a potential explanation why a spirituality connection could enhance quality of life. Other distraction mechanisms that women use in order to overcome the fact that they're sick, and it's really very interesting. When you go and talk to these women and hear their experiences, you think you're coming to give them strength, to give them support. Like when I was listening to the focus groups, I actually when we were done with the focus groups, I actually was inspired by these women. Thinking I'm going to inspire those women, I ended up being inspired by these women. It's really it's enormous how much strength those women shared with us, and the positive energy that those women have. Minding some of them, were stage 4, and some of them actually, unfortunately, passed away after the study. But when we were talking to these women during the study, I mean, the energy that those women had were super inspirational, honestly. And fear of disease recurrence, as I said, was commonly cited as well. And in conclusion, our study strengths are mainly in the fact that the study was a triangulated study, that it combined qualitative and quantitative methodology. And this is actually very important because when you collect quantitative data, you can explain patterns, groups, distribution. But when you go into trying to explain what your patterns and distributions are, combining it with combining a quantitative methodology with qualitative methodology could be extremely instrumental. Another strength in the data management and analysis was independent from the translation process, meaning that different people were engaged in the different processes of the study, which this is important because you don't want to bias your study findings. And study limitations, we had a limited sample size, and basically the women were volunteers, so maybe in our group we had more cooperative women, and maybe this is why maybe we thought that those women were very inspirational. Maybe the less inspirational women were not willing to be part of our study. And in any validation study, the first step after you translate and phase validate is that you need to do a content and construct validity study. Which means you need to make sure that your items stick well together, they're measuring the concept accurately, and when you re-administer the questionnaire over time, you get the same results, and that's reliability. So my next phase following this study is to conduct a content and construct validity on this instrument. And my third step after this validation study is to use this quality of life instrument in a randomized clinical trial that aims to enhance psychosocial well-being among women survivors from breast cancer. Why am I noting the steps is to let you know that research is a cyclical process, that from one research study another evolving idea emerges, and there's really for research there's no limit. It's all you have to do is use your creativity, and if you're lucky enough you get funding to do your to do your study. I would like to acknowledge the Reproductive Health Working Group. The Reproductive Health Working Group actually carried this phase validity exercise. What we did is we did the same study concurrently. So while I was doing the study in Lebanon, the same study was being done in Palestine, in Turkey, in Jordan, and in Syria. And we were funded by the Ford Foundation. The acknowledgements also to the Bastille Cancer Research Institute at the American University of Beirut. The nurses and the staff were really amazing. And definitely last but not least to all the women who made this research possible. And thank you.